So I'm going to be talking about surgical management of inflammatory bowel disease. So what are the topics? Looking at the key points. When is it indicated? Different approaches between Crohn's and ulcerative colitis, some of the benefits, and I'm going to just make a few comments on the postoperative management as well. So the clinical pearls in IBD surgery. Number one, failing to prepare is preparing to fail. So we need to recognize failure of meds. That's kind of number one. When these meds aren't working and you've gone through a few, we have to definitely recognize that possibly surgery is indicated for sure. And it's also very important to say to the patient, they are not the failure. Often they talk about, oh, I'm a failure. I failed this, I failed that. No, the patient is not a failure. The medications failed you. And surgery does not have to be a last resort. If patients aren't having a good quality of life, we need, they can go to surgery. We don't have to go through every medication possible, and they're suffering during all this time. Surgery, we can go ahead with surgery when it has to do with quality of life, steroid dependent, all kinds of things. Recognize complications of surgery. If there's a stricture or abscess in Crohn's disease, toxic colitis, and a cancer, these are all potential complications of the disease and that we need to take care of. When they have an abscess, you definitely want to drain the abscess preoperatively, particularly in Crohn's disease. So we do not want to go into an abdomen that is septic. So we need to definitely drain that, get them on antibiotics, and get that resolved the best we can. You want to minimize corticosteroids. They don't have to be totally off. If we can get them down to 10, that's 5. If we can get, down to 5 or whatever, that's even better. But they don't have to be totally off. We want them on the lowest dose. We want to optimize nutrition as much as possible. So checking, if there's greater than 10% weight loss, body mass index, albumin, okay, then we need to possibly optimize them beforehand, before we take them to surgery. So failing to prepare is preparing to fail continues. We want to help patients quit smoking, and we know this is hugely difficult, but we want to get them off as much as we can and as minimal as we can. We want to improve their patients' quality of life. That's what this is all about. Surgery can improve their quality of life. And we want to set postoperative expectations. Surgery is not a cure in Crohn's disease. They're going to need to get back on medications. Talk about bowel functions. Sensation may be altered. Are they going to have an ostomy? How many stools are they going to have maybe initially, which after they heal, things will go down and they'll have a less number. The recovery period. What does that look like? What is my diet going to be? Like a low residue diet, lifting restrictions often is 10 pounds. And work, we usually give patients 6 weeks off, that's the time of recovery, but that's individual and you have to see what's going on with your patient, and they know their job, and often they know if they can go back to work or not. I tend to find patients who want to go back sooner than later. And post-operative monitoring. Want to look for recurrence in Crohn's disease. That is absolutely necessary. And also extremely important is shared decision-making. Engaging the patient, asking the patient preferences, and is the patient willing to accept surgery? We want them to be engaged and with us in the plan for surgery. Otherwise, things just fall apart and they don't have good outcomes mentally or whatever. So we definitely have to engage them in the process. And then they're more accountable for following through with the plan. So ulcerative colitis, when is surgery needed in UC? So about a third of patients are going to require surgery. Elective cases, usually a failure of medical therapy or steroid dependency. Complications or side effects of medications, if they have dysplasia or a cancer. If they have refractory extraintestinal manifestations, that's also a reason. Growth failure, particularly in pediatric patients. And don't forget, decreased quality of life is of utmost importance as well. Urgent situations would be like a sepsis or fulminant colitis, hemorrhage, colonic perforation, and toxic megacolon. So clinical pearls in UC. Typically, it's 2 or 3 surgeries involved, and there's a minimum of at least 3 months. It can go longer, but we feel like we need 3 months for the adhesions and structures in there to soften, and that we're not going in and the adhesions are strict, and it's just, much more risk for complications. Often involves an ileostomy, which could be either permanent or temporary. The entire colon and rectum are removed in almost all cases, regardless of how much colon is diseased, because it comes back. A rare exception might be doing an ileorectal anastomosis, and we've looked at that sometimes in patients, some of the older patients, or that they just can't deal with an ileostomy at all. I mean, at all expense, they don't want it, and they don't, just don't want to deal with it, then we might do an ileorectal anastomosis. But again, that's not very common. And then those patients have to have that rectum definitely monitored. And I could see this more probably in a patient who might have had a cancer with the ulcerative colitis, and really it was more mild disease, or, they were maintained. That could, be an exception there too, but definitely that rectum has to be continually monitored, at least annually. J-pouch, we kind of say it's not really for patients with Crohn's disease, because we say nothing like a pouch to bring out the Crohn's, because we're holding stool, which, can change that microbiome back to kind of like that Crohn's kind of deal. But an exception is if they've never had small bowel or perianal Crohn's disease, that we might be able to do a J-pouch, and we have some success with that. But the huge caveat is there, to the patient, we don't know, it could come back, but we have had some success. Now, clinical pearls in UC typically, did I go backwards? I sure did. Here is toxic megacolon, what that looks like. Look how the bowel is absolutely huge. I can tell you when I first started at the University of Chicago, we had like several of these a week because we didn't have medications like the biologics. We had pretty much only steroids and asulfidine, just starting to look at, the 5 ASAs. But this was hugely common. And obviously, what is the biggest risk with this? Perforation. A rescue diverting loop ileostomy, that would be an alternative to an emergent colectomy, particularly in a setting of severe acute refractory colitis. The primary aim, obviously, is to avoid an urgent or emergent colectomy. That would be the primary reason. If they were, nutritionally, just it's not good to go in there and remove the colon at the time, then this would be an option. And the secondary aims, obviously, would be to decrease steroid dependence or bridge to medical therapy, improvement in enteral intake or nutritional status, and allow a more elective laparoscopic definitive procedure or colon salvage. I can tell you with this, we have done it a few times because it was just too risky to even go in, but this doesn't last long because, again, there is ulcerative colitis in that entire colon. And so the bleeding often does not go away because it's still there. So these patients often within a couple months or whatever, it doesn't last too long. We really need to take it out because they can continue bleeding. I mean, the thought is when you divert stool from there, it's definitely going to be better, but some of them often have ongoing bleeding. Proctocolectomy with an ileostomy, that's resection of the entire colon, rectum, and anus with a permanent stoma, as you see there. Brook ileostomy, that's the name of Dr. Brook, who would come up with it. That is an end stoma, and you can see how that is created there. So the total abdominal colectomy with the Hartmann's pouch ileostomy, the rectum remains. So in this procedure, and I call it a staging procedure because the rectum is still left in place. So we could go ahead and do a J-pouch procedure here. So we're not sort of, you know, breaking or doing away with all bridges here. They could still have another procedure. If they're trying to decide with the ileostomy, can I tolerate this? Oh, this isn't so bad. Maybe I want to keep this, or, I think I do want to move forward with the J pouch. So the rectum is still there. So we can bring in a J pouch afterwards once we remove it. So it's kind of it's a holding pattern for what patients might want to do. And some of them do decide, yeah, I'm happy with this. I really think I want to keep this versus maybe moving on to a J pouch. And I tell you, I am seeing that a little bit more these days where they kind of say, you know what? The stoma's not so bad. I'm doing well. Why mess with a good thing? But then we would have to take the rectum out in a setting like that. Now here's the J pouch. So stage 1 is what we were talking about, taking the entire colon out, leaving the rectum in place as a placeholder. And they are with that for about 3 months to allow healing to go on, get them off all IBD meds is number one thing, and get them healthy again and nutritionally better so that they're better able to go through the second stage, which is then removing that rectum that was our placeholder. The J pouch is created, as you see it there, and they have a diverting loop ileostomy. And as you can see, it's formed there. And this is not an end stoma, which would protrude out more. These are often a little bit more flush with the skin. And sometimes there's like issues with getting a good seal. So a great asset here is a phenomenal ostomy nurse to help them with these problems. And then the third step is then takedown of the ileostomy, which you can see there, and they are then fully continent with stool. Now here's how the J pouch is formed. As you can see, you take the end of the small bowel and it's looped back on itself, and that becomes the new rectum, and it's an open area, and it then is attached down to the anus. And you can see the anal sphincters are all there. Everything is still there in place. And you see the diverting loop ileostomy there on the top. And then the anastomosis, how it is done, there's 2 different ways to do it. One is the hand-sewn anastomosis, where the J pouch is attached to the anus. And when I first started, they were all done that way, every single one of them. One of the things, and we weren't doing laparoscopic. These were all open procedures. And the issue with that in the beginning, more or less, they were a little bit more at risk of having some incontinence because you're way down there low in that sphincter area doing the anastomosis, so they get stretched a little more. So we would see some leakage of stool in the beginning, but give it six months to a year and it would go away as everything healed and settled down. They do strip that inner mucosa there as well when they slip that in there. So there is no mucosa left in the distal rectum. And then over here is the stapled anastomosis. This came about afterwards, after a while, and they're thinking, hey, those sphincters are down there, but if we leave in maybe 1 to 2 centimeters of rectal mucosa, so you can see the anastomosis is above the sphincters, that this may have less leakage of stool. And it does. It did in the beginning. It definitely did, particularly when procedures were open. But but I can tell you now what I see is between the two with laparoscopic, I don't really see the leakage that much with hand-sewn anastomosis anymore. The other aspect here is in the stapled, you are leaving 1 to 2 centimeters of rectal mucosa, which could put them at a risk of having ulcerative colitis or bleeding and a little urgency there. For the most part, I don't see it often because it is so small, but it could happen, and I have seen it in a few, and we've had to go back in and basically remove it, or the patient will say, I want to go back to a permanent stoma. But that is one of the things there. The other risk there is developing dysplasia or a cancer back in there. And that is mostly with patients who maybe had dysplasia or a cancer in the sigmoid or rectum area there. In those patients, we often kind of would recommend a hand sewn as much as possible because believe me, I have seen that come back. But they say if the patient has cancer or dysplasia higher up, that it's a less risk. So we still are doing both of these. The key with that stapled anastomosis and that 1 to 2 centimeters left in, that needs to be biopsied annually to assess for possibly cufitis or the dysplasia. And depending, after a few normal scopes, maybe you could wait a couple years or whatever. It all based on patient risk. Here are the goals of J-pouch. What is a J-pouch meant to do for you? Get rid of UC, get off all IBD meds, steroids, biologics, etc. Restore bowel continuity. There's no permanent ostomy. Number one to me is improve quality of life. That's what a pouch is supposed to do for you, as well as all those other things. And it requires resilience on the part of the patient. They have to have patience and self-management because there is an adjustment with a pouch in the first year or more. And 90% of patients are happy with results and would recommend the surgery to others. I really talk about this a lot, and I'm going to talk about it more when I get to the J-pouch segment, but discussing these goals is extremely important in the beginning. Now, here are the complications of a J-pouch, pouchitis, 50% overall. It really is like a 50-50 with them. Cufitis, lower, 10 to 15%. Anastomotic leak, and that's where that pouch is attached to the anus. Leaks can be about 6 to 10%. Pelvic sepsis can result in pouch failure. Often that is, when there is kind of a leak and they're getting, septic in there. Pouch fistula, sinus tracts, they can develop as well, 22 to 33%. And that can result in pouch failure as well. And then you're thinking, fistulas, is this Crohn's disease developing? Or is this actually because the anastomosis, it's a surgical thing and they have a leak in that respect? So you can't always say, okay, no, I think this is Crohn's disease. No, we have to further investigate that. Anastomotic strictures can occur about 16%. And I would say those would be more common in the hand sewn because it is a low anastomosis. So these patients, I do digital exams every time I see them in clinic. Twisted pouch syndrome, this is extremely rare, but I've started seeing this a little bit more in the last year or so. And I'll show you eventually what that looks like. Dysplasia, neoplasm, 3 to 2.7%. Again, mostly in the cuff, and especially if the pre-op diagnosis of dysplasia or cancer in the rectal sigmoid area. Sexual dysfunction, 15 to 35%. I mean, there's a big variation on that. I really felt that the laparoscopic approach and using robotic approach really reduced that risk. In men, they can have impotence, decreased erections. This can occur just in the beginning because those nerves for sexual function run right along the pouch. Give this, I say, maybe 6 months or so, and this could all kind of turn around. The one thing is the pill does work with these patients and it helps. In women, dyspareunia, that's pain on sexual intercourse. That's because the pouch sits right there next to the vagina. And so they may have some pain on intercourse because of that. Give that time. It can also help, or pelvic floor therapy can help there too. But I don't see that a lot either. Again, give it the healing to take place, and that soon resolves. Female infertility can be reduced as well. Again, I find the laparoscopic, that approach has made a huge difference down there as well. Crohn's disease, about 10 to 13%, usually develops later, and definitely can often result in pouch failure, or then guess what? They're back on biologics. They're back on everything again. Pelvic vein thrombosis, about 7 to 10%, and that can result in pouch failure as well. Most common is the pouchitis, and again, 50% of patients can get it, and they can have greater than one episode. Symptoms, urgency, all of this feels just like ulcerative colitis all over again. And it's a reaction of the pouch lining to the microbiome flora. How do we treat it? Acute pouchitis, usually a 2-week course of Cipro or Flagyl. You know, those are the common ones we go to. You can go to amoxicillin, rifaximin, etc. Some patients say right after that first pill, they're better, but they need to stay on it for 2 weeks. And then you have the chronic relapsing pouchitis. A small percentage, but again, you're treating it with the antibiotics. They often may need a much longer course for being a month, 2 months, or minimizing it to what still works. But then there's a point where you get to the antibiotic refractory or Crohn's disease, and then you're back on all those meds. And there is a role of probiotics in preventing relapse or making symptoms seem less. And that's been scientifically looked at too. Here are the expectations with a J pouch: 4 to 8 stools per day, best 4 to 6. We want them to be 80% thickened, can delay usually a bowel movement 1 hour, some can eventually 4 hours. Should not see little or hardly any urgency to pass stool, or I'd be thinking colitis. There usually is no leakage. If it is, it's in the beginning, or maybe at night where they're in a full-blown sleep and they're not feeling anything come down. Wet ones, moisture barrier ointments prevent obviously the rash. They can eventually eat most foods without difficulty, but everybody varies. You know, spicy, high roughage increases stools, and long-term follow-up. And I found this out myself when we were initially doing research on pouches, when we started them at the U of C, and we were keeping data. And I had a questionnaire. I had them doing stool diaries and all this, and doing blood work. We were doing all that stuff. And then they finally said to me, Michele, I think we got enough information. You don't have to collect any more data. And I'm like, whoa, no, no, no. And function improves over time, and it can take up to 2 years. And what patients tend to do, you tell them what good pouch functions are, and they forget over time, and they start accepting the bad results. So no, no, no. They need continual monitoring, and that's where my J pouch clinic came in. So risk of surgery early: all abdominal surgeries, the usual: infection, bleeding, blood clots, dehydration, particularly with the stoma, postoperative ileus, rectum and anus removal, proctocolectomy, or a J pouch. Injury to ureters and nerves is possible, affecting urinary flow and sexual function, fertility initially. J pouch anastomotic leak, peripouch abscess. What are some late complications with the proctocolectomy? Delayed perineal wound healing. Some patients take a little more time for that perineal wound to heal, and I follow them till it is totally healed. If it's not healed by 6 months, then usually we take them back to the OR and sort of debride the area and redo it again, and often that works. Stoma complications: hernia, prolapse, retraction. Small bowel obstructions can occur because adhesions perhaps in there developed and cutting off the flow. With a J pouch, it's pouchitis, pouch function issues, and if they could develop Crohn's in the J pouch above the small bowel usually. So benefits: technically a cure, eliminates bowel cancer, risk of the colon, get off all IBD meds, restores health quickly. And the pouch restores continuity through the anus, no permanent stoma, and may be done with minimally invasive techniques, which now we pretty much try and always do, the laparoscopic assisted or robotic in most cases, and it does give a better quality of life. So Crohn's disease, when is it needed? The things in the black are all the ones that were also for ulcerative colitis, but what is different here with Crohn's is the fibrotic obstructing strictures, the fistulas and abscesses, and perianal complications. That's what's different here. Key points, typically only the segments of bowel affected are removed. So healthy bowel is left intact or mild disease, may remain. For example, they have a terminal ileum with an obstructing stricture, but they also have very mild perianal disease. So we're going to only resect the stricture and we'll work on treating the perianal disease. You're not going to take it all out just because. So you only remove what you need to remove because remember, they can have recurrence and we can't just keep removing bowel unless we have to, or they're going to end up in short bowel syndrome. Perianal abscess or fistulas with ceton placements. Usually it's a combination of medical and surgical treatments with these perianal fistulas. Crohn's disease recurs at the same location over time. So if it's an ileocecal area, it recurs right back there the next time. Exception to the rule, if Crohn's disease was only involving the colon and none in the small bowel, if we do a proctocolectomy on them and they have an ileostomy, the Crohn's may not come back because we're not holding stool. The stoma, it's a free flow out, so there's no holding stool there. So they may not develop Crohn's again. But those patients have to be monitored. And particularly if we think they're at risk, they're going to get an ileoscopy that may be 3 months, 6 months, or whatever, but we definitely want to be sure that it doesn't come back. Because where is it going to come back? It will come back at the stoma site if it's going to. And we need to assess, like I just said, IUS or fecal calprotectin at 3 months, if a high risk ileocolonoscopy in 6. That's how we usually do it. Here are what strictures look like, on a small bowel follow through. I've got the blue arrow sort of indicating on these different diagnostic tests how you can note or see a stricture. Resection of ileocecal Crohn's disease segment. This is the most common bowel surgery for Crohn's disease. As you can see, the segment, the cecum and ileum are resected in that area and they have an ileocolonic anastomosis. Now, sometimes a temporary ileostomy is made if there was Crohn's disease down in that sigmoid area and we did, a resection or something there of a short segment, then we would give a temporary ileostomy because healing down there in the sigmoid area is a little bit decreased. And so sometimes we'll do a stoma there, allow that to heal, assess that, the anastomosis, the disease, everything is okay down there, and then just connect them. It's not often that happens, but it can, and it's just because of the decreased healing in that area. Bowel-sparing intestinal stricturoplasty. No bowel is resected. As you can see in that first segment, you see the stricture area that's marked out. Disease is pretty much not really there much. I mean, the stricture is, formed because of flare and healing, and every time laying down more scar tissue. And so doing a stricturoplasty, we're going to take the area, we're going to make a longitudinal, a horizontal cut across that area, and then we close it horizontally. And what that does is opens up that strictured area. And we haven't removed any bowel, okay? So the stricturoplasties really work well, but yes, they need to be on therapy and you need to reassess at a point, is there what's going on there disease-wise. But this is definitely a great bowel sparing therapy for these patients. Recurrence rates are extremely low. Now, here's something Dr. Fabrizio Michelasi, when he was at our institution, he came up with this procedure that is for long strictures. I'm talking about really long strictures. And to remove all that bowel would give them short bowel syndrome. So what he did, the thought is taking that entire long segment, and he would basically cut that in half and overlap it. As you can see, it's overlapping, opening up that entire area. So the surface, mucosal surface is pretty much all there for absorption of nutrients and everything. And this has worked out very well. We've done follow-up studies. These patients do extremely well. Very few do we ever have to go back and take that out. So that's a great bowel sparing procedure for excessively long strictures, in Crohn's disease. Now here is abscess within the sphincter muscles in Crohn's. This is how setons work. So they're like silastic setons. We often use those that they look like a rubber band, actually. They keep the fistula tract open so the abscess can drain. And you see there on the left, the abscess within those sphincter muscles and how it tracks to the outside, but it tracks to the inside to the anal area. And therefore, we take the seton, it's like a rubber band or whatever, string it in through that area and then pull the ends together on the outside and tie it off. And that stays there to keep that abscess draining. And sometimes you see ones where they don't have a tail on them. I like them to have a little tail because if they don't, it can turn around and that overlapped area can get inside the tract and clog it. So with the tail on the outside, it doesn't allow that seton to turn around. And that's something you always have to check. It could happen, but less likely with this, because otherwise we're, blocking the tract here and it won't drain. So that's a very key aspect to that. Now here's complex perianal fistula abscess network diverting. We usually hear in those blobs of tissue, those are actually all fistulas, and it's hypergranulation tissue that is formed because of the constant drainage. And you can imagine when you see a patient like this, I mean, they're draining. This is very severe chronic perianal Crohn's disease. This is awful when you see it. And what do we have to do there? We have to give them a diverting stoma, and we put in like setons and different stuff. And you see the fistulotomy opening the areas there and putting in all these setons in. And the diverting stoma, we definitely want to get the stool flow away from there. This is all sepsis in that area. There's not a whole lot you're going to do with this because there's so much sepsis. And I would say that all of these patients, very few can we ever take that stoma down, because if we do, this all comes right back. So these are often, let the sepsis, let everything, settle down. They keep that stoma, and eventually we can maybe try and resect the anus and everything out of there, but often we need a plastic surgeon to help us close up these wounds. It's very complicated when you see it. And I'm going to tell you, I've seen some young kids come that have it this bad, and I have several that I've seen. They weren't being followed correctly for Crohn's disease for quite a while. They presented, they're just smelly. They have all this stuff. They're often very socially inept. They also live in their basements on their cell phones. And when I asked them, are you getting out? Are you doing anything? No. I said, well, do you have friends? Oh, I got a lot of friends, Michele, a lot of friends. They're from all over the world. And I go, you don't have any friends? They don't want to go out. They don't want to socialize. So they just hang in the basement. It's a very difficult population to deal with. And it takes a lot of time and work with these patients to get them to come around. Then there's the mesenchymal stem cells. It still is kind of in clinical trials. It's for fistulas. We've done some of these studies. The key is they really cannot have real active Crohn's disease down there. It doesn't always work in them. If anything, you have to really get the fistulas and the disease very quiescent before this will really work. This is how it's done. You look at the fistula tract, you stitch off the opening on the other end, and then you put in the stem cell and seal that off, and that stays in there. And eventually, over time, it will heal. Now, they have had some success, but cannot have active Crohn's down there, that's for sure. And these were some of the studies. Obviously, the exclusion, rectal vaginal fistulas, rectal and or anal stenosis, active proctitis. There's things that, and we didn't want them having a diverting stool because we wanted to see all this going on. But I know initially they thought they were having good outcomes, but it's still, they got active Crohn's down there. It's sometimes doesn't work. You have to get it under control for sure. Here's a resection of the entire colon and rectum with a permanent ileostomy. As you can see there, everything's out. And as I said before, it could be curative for Crohn's disease if it was never in the small bowel or the perianal area. Here's the other, Dr. Fakera here. I actually went to Japan with Dr. Kono, and they used this the Kono S, basically anastomosis after Dr. Kono, and it's a functional anti-mesenteric end-to-end hand-sewn anastomosis to help prevent recurrence of Crohn's. Here's the factors that lay around the anastomosis, because they're thinking it always comes back at the previous resection. Well, there was ischemia, denervation in the area, the microbiome plays a factor, fecal stasis in that area, and there's the local cytokine production. That's what all is going on in that area, and it's all interrelating. So how is it performed? You see the dotted lines where they're resecting the colon there and the small bowel, and then you see where they're intersecting there with the vasculature and the mesentery. And they're resecting that out in A, and then in B, they bring the two ends together, close together, and that becomes a supporting column. You know, it's stiff there, some with these stitches. So then go to C, and you see the supporting column there, and then on each side, they're making a horizontal cut. And then in D, you see the supporting column, but then they're bringing those two ends together and stitching it together, and you see it in A. And that supporting column helps keep it open so it doesn't narrow down. That's the purpose of this. And the division of the mesentery, it preserves the vascularity and the innervation. As you can see, a resected area with the Kono S. In the conventional, they do, it's always usually a little larger cut there. Key principles: division of the mesentery, minimize disruption of the vascular supply and innervation, preserves the vascularity and innervation, creation of that supporting column, which maintains the shape of the anastomosis, and creation of the wide anastomosis so it doesn't impede the flow. Is it safe? This has been the statistics on it since they incorporated this. And as you can see, it's really, there's very low risk of complications. So the benefits and risk of Crohn's surgery: removes the disease segment, significant improvement for most regarding symptoms, nutrition, quality of life. Laparoscopic, again, laparoscopic assisted robotic techniques, also very helpful in these surgeries now. What are the risks? Major surgery incurs increased risks, such as infection, blood clots, pulmonary embolism, dehydration, ileus postoperatively, obstructions, and multiple surgeries. That's kind of with every surgery, but in Crohn's, that risk of disease coming back, etc. Anastomotic leak is always a risk, short gut with multiple surgeries, diarrhea stools, or they have to be on TPN if they lose an extensive amount of bowel, possible ostomy, incontinence of stool with perianal procedures, such as with setons or abscesses. And most importantly, it's not always a cure. Postoperative recurrence is common. So here we jump right into the postoperative management. So here you often see the natural course of postoperative disease. Histologically, they can see it at 1 week. Endoscopically, 70 to 90% by a year. Radiologically, you're going to see tissue damage. Clinically, symptoms 30% by 3 years, 60% by 5 years, and 50% by 10 years. And they usually end up in surgery here. So postoperative endoscopic evaluation should take place 6 to 12 months after surgery to assess for recurrent Crohn's disease with changes in treatment based on those findings. Here's the relative risk factors for recurrence. Early age at surgery, less than 30, because think they have a longer time living with the Crohn's. So there's a longer time for Crohn's to recur. Can be a short time to first surgery, often already means it's probably a pretty aggressive type disease. The ileocolonic disease is more at risk for recurrence. Active cigarette smoking, so important. As I said, that's one of the #1 recurrence factors. The penetrating phenotypes, your fistulizing disease is often definitely higher risk for recurrence. If they've had prior resections, that can be a higher risk. And then you question, could it be the anastomosis as a factor? We can't say 100%, but could it be? And then perianal disease. Those are all higher risk for recurrence. So how do we prevent it? Medical therapy. Prevent or limit disease recurrence. Initiated once. There are no signs and symptoms after of an infection post-op. And in my post-op clinic, we have the IBD, APN. She comes to that clinic as well. And the two of us together, I clear the infection rate, and she is right there to get him back on medication and get him on a monitoring schedule. So it's very important for these patients to have the post-operative instructions. Let them know ahead of time. Here's what the plan is going to be post-op. This is what medication you're going to go on. This is the plan for, doing the monitoring. So we tell them that beforehand, and then with her in clinic, they're with me. We got them right on, set up with the plan. And I'm telling you, that process, we do not lose these patients. In the past, they'd kind of drift off and like, oh yeah, it's done now. I don't need to come back. We now catch them right then and there and get them set up with a plan. And you want to discuss preoperatively and postoperative visits, discuss risk factors for recurrence, engage the patient and discuss the plan of medical treatment based on risk, discuss objective monitoring for recurrence, communicate, initiate plan postoperatively once incisions are healed and no infection is present. And communication is key between the gastroenterologist, the surgeon, the primary care provider, and the patient. Everyone needs to be aware of the plan. Now, with all this, surgery rates, with all the new medications and everything that we have on board, they have improved, but they're still high. Look here, before the year 2000, with ulcerative colitis and Crohn's, the 1-year risk, 5-year risk, 10-year risk. And you see it's a high percentage. It's improved, but here we are after 2000. You can see it's improved, but we still have risks. So, we're making progress, but we don't have that cure or anything yet. So we still have to, that's why that post-op recovery is so important. So surgery and IBD, necessary at times, discuss early, not as a last resort, match appropriate surgery to the patient's case, shared decision-making and ask patient preferences, include them, engage them, consider consequences of no surgery. If a patient doesn't want to have surgery, then we need to sit down and say, but if you don't have surgery, here's what's going to happen. Your disease is going to get worse. You may higher risk of complications. You may end up with a stoma if we wait, a lot more complications. So that's very important to discuss with patients. If they don't want surgery, you really have to cover what are the consequences. Special attention to issues regarding the stoma and the J pouch, Crohn's recurrence, prevention post-operatively, get them back on meds, and maybe the Con-OS anastomosis is a factor. We're not totally 100%, but we have seen good outcomes. And again, the team approach. Medical, surgical, ostomy nurses, nutrition, dietitian, psychological, and behavior therapist, all important. This is a multidisciplinary care of patients. And here's some resources just quickly here that are available on the foundation website. There's resources for providers. Remember, don't forget, you get a free membership for your patients with your referral. So when I'm in the clinic, I am discussing with the patients, are you a member of the Crohn's and Colitis Foundation? And I find quite a few that aren't. And I say, hey, I can get you a free membership for a year. We'll refer you. And if you guys, your institutions refer them or you do, they get a free membership for a year. And then there's other resources here that I have available as well, the jpouch.org, ostomy support groups, etc. And here's web resources for nurses and advanced practice providers. See all the special things. We have IBD tips, interactive cases, best practice library, the APP IBD preceptorship, which you guys all know and heard of that, research education, IBD educational videos, professional membership. So there is a lot of great stuff here for you and for patients.